Alright, we're going to do this again. This is my AEMT Supraglottic Airway skill demonstration, take 2. Here we have my patient. I'm guessing he's about 50 to 70 kilograms. OPAs, syringe, capnography attachment for the monitor, bag valve, mask, oxygen, and lubricant, and a commercial securing device for the advanced airway. So, here we go. First I'd like to say, okay, here we go. To begin, PPE for BSI. Is my scene safe? I hope so, thank you. Hello sir, can you hear me? Can you hear me? I'm going to palpate for a carotid pulse. I feel one, but I don't see any chest rise or hear any breathing, and there's definitely no responsive. He's unresponsive. So immediately I'm going to measure my OPA, lift the jaw and the tongue, and insert it like so. And begin ventilating. Making sure that. Yeah, now I've got chest rise, got a good seal, proper head alignment. I'm going to ventilate every 5 to 6 seconds for a total of to achieve 10 to 12 respirations per minute. So when I put in the OPA, the examiner informed me that there was no gag reflex and the patient accepted the airway. But now I've been told the patient is oxygen saturation is 85%, which is unacceptable. This patient needs oxygen. So one more. We're going to attach oxygen to my bag valve mask and put it at 12 to 15 liters per minute. I'm just going to go 15. Now we got good chest rise. So now I'm going to keep an eye on the pulse ox, but hopefully we'll get a significant change in the saturation of the blood. So after about 30 seconds, my examiner will auscultate the chest and confirm bilateral equal breath sounds, and tell me that medical control has ordered a supraglottic airway. So I'm going to ask my examiner to take over. We're going to imagine that's happening. The ventilation, so we can pre-oxygenate the patient while I inspect my equipment. I've selected a number 4. It might be the right size. And it takes 30 milliliters of air to inflate the seal. Let's test that. Yep. No leaks. No cracks. The airway is in good condition. I can evacuate the air. Set this up for 30. And then tell my partner, examiner, alright, at the end of the next respiration, I'm going to ask you to remove the BVM and step aside, please. Okay. Alright, so now I'm going to perform a tongue lift, chin lift to get that out of the way. And I'm going to insert, oh, I forgot. Normally I would lubricate this, the distal tip, with one of these. It's more than that, it's the whole back and everywhere pretty much, mostly the back. All right. Okay, so it moved a little, hopefully it's seated properly. Got a little bit of air along chest rise. Yeah, Let me try pulling it out a little bit, adjust as necessary. Ah, that's much better. All right. Yeah, we got good chest rise, decent seal. Now, to confirm, well, first we're going to listen. Let's oscillate. So I'm going to ask my examiner to hold onto this, make sure the airway tube stays secure, doesn't move, to get dislodged, and ventilate 5 to 6, every 5 to 6 seconds, while I oscillate 4 quadrants of the chest and epigastrum. Yeah, we got sound. The epigastrum would be right around here. And I hear nothing. And the epigastrum, but good equal bilateral breath sounds. Yeah, in the lungs. So, the next stage is to double check placement with capnography. So I'll take over the respirations. Sorry. Still got good chest rise. And now my capnography collector probe can attach to the monitor, cardiac monitor. I'm going to look for a nice waveform in the 35 to 45 millimeters of mercury range for CO2 at a rate of 10 to 12 per minute. All that's left to do now is secure the device. I will ask my partner to take over ventilations again and make sure that the airway stays secure while I apply the commercial securing device. And right, we still have very good chest rise. This airway is secure. And so from this point, I'm going to, my examiner will ask me, how do you know you're getting adequate volume on each respiration? And I will say, look for chest rise. And from now at this point, I'm going to make sure that it's secure, stays secure, and I'm going to monitor the capnography and pulse oximetry as I ventilate the patient. All right, thank you. That is all.